Very good afternoon, one and all. At the outset, I am first of all very thankful to POPMA for providing me this opportunity of expressing my experiences regarding this topic of oral lichen planus. We have had the opportunity of seeing many cases of oral lichen planus in past few years, and still the journey of learning continues. So to begin with, so next slide. When we talk about oral lichen planus, most of the times when the patient comes, he comes with a complaint of pain, difficulty in eating, and the emotional challenges related to the fear that is in his mind that he might develop cancer at some stage, or is the presently seen lesion a cancerous lesion. So when we are treating such a case, we need to have an integrated approach so that we are able to decrease the symptoms of the patient regarding pain and discomfort. We should be in a position to eliminate the occurrence of any further lesions and also prevent its conversion to oral cancer. When coming to the pathogenesis, most of you are already aware. Just to brief you in short about the pathogenesis, because this relates with the treatment strategies that we are going to apply in the future slides. What we know of lichen planus is that there is some unknown antigen or a trigger. What it does, it causes the autoantigen expression by the basal keratinocytes in the epithelium. Now, when these autoantigens are expressed, what happens is they are presented by the Langerhans cells to the CD4 plus helper cells and CD8 plus T cells, which further get activated to produce interleukin 17, 12, 23, and interferon gamma. Now, these cytokines lead to proliferation and activation of the cytotoxic T cells, which lead to the basal cell apoptosis, what we know of in the oral lichen planus. Now, it has been found out through the studies that refractory lichen planus, the use of anti-interleukins 12, 17, and 23 that we'll see in the future slides, that this is very helpful. Now, coming to the other pathology that is related is the mast cell degranulation that happens in the connective tissue. When the mast cells degranulate, there is a release of two important things, that is the tumor necrosis factor alpha, which leads to the migration of the T cells from the capillaries to the extracellular matrix. So the more the T cells, the more the possibility of the lesion progressing. Kinases which are released from the mast cells activate the matrix metalloproteinase number 9, which destroys the basal cell membrane of the epithelium, below the epithelium, and this creates an easy way for the migration of the CD8 plus cells further towards the epithelial cells, and which recognizes the MHC class 1 antigen on the lesional keratocytes, leading to its further apoptosis. So, whenever you see a case of oral lichen planus, the first and the most important thing is to categorize the case thoroughly. Whether it is a case clinically of reticular pattern or a combination of reticular with erosive, a purely erosive form of lichen planus, desquamative gingivitis, or are we dealing with a case of a healing lesion? So clinically, if you have categorized, the next step is also to rule out whether this, sir, previous slide, it is also important to rule out whether this lesion is outside the site of the tobacco placement, because if it's a site of tobacco placement, the leukoplakic lesion, erythroplakic, should be the first to come in our mind. Second, is there any related nearby tooth which is having a dental restoration which could have caused a contact hypersensitivity reaction? Now, also when you are trying to confirm with the histopathology, always check whether there is any component of epithelial dysplasia. Also have to rule out, as I said, oral lichenoid lesions. Now, here there is a case of what I just mentioned in the previous slide, oral lichen planus versus oral lichenoid lesion. So this was a case purely of oral lichenoid lesion, where this patient had silver amalgam restorations in relation to the left and the right side lower posterior teeth. The lesion developed, like there was the history of these silver fillings from almost 8 to 10 years, but the lesion was developing gradually since like last 5 years. Patient also gave the history of allergy from the toothpaste and non-veg diet. So sometimes the non-veg diet also exacerbates the lesions of the oral lichen planus. So in coordination with the referring clinician, All the fillings here were replaced along with the treatment, which after 5 months of treatment was uneventful. So this clarity is very important, differentiating oral lichen planus from the oral lichenoid lesions. When we are dealing with the patient, the first thing is to understand the history, the background of events that would have caused the lesion. Because many a times the patient will not expose, but we have to really sit down with them and understand that is there any history of stress, any anxiety, reason of depression, or the fear that which might create a vicious cycle of again stress, that is, do they have cancer? So we have to actually sit down with them, talk with them, and try to understand the history behind it. This is a very important first step that we have to take. We also have to not to miss to find out, ask questions regarding any triggers, is was there any dental procedure performed that could lead to stress, any medications that they were taking, because anti-epileptic drugs are related to the lichenoid lesions. Then oral injuries, like is there any reason for trauma, injury, a sharp cusp or an edge which is causing the lesion? Then, as I told in the last slide, some might have allergy to some Ayurvedic toothpaste, especially the clove oil which is there can be allergic. Then some toothpaste which have the sodium lauryl sulfate content can also be an allergic component. Apart from that, smoking also potentiates triggering. So, what is important? Start with the peaceful detailed talk. Now, this is a very important part in the beginning of the treatment planning, that the lifestyle alterations. So, we have to convince our patients to avoid any kind of stress. And in this, meditation pranayam helps a lot. Any form of exercises, because it boosts up our immune system in the right way. Then maintaining of good oral hygiene, because there are a lot of studies which relate microbial flora with the oral lichen planus. We have to ask them to have good alteration in the diet related to, like, they should increase the intake of coconut water. They should avoid having any hot, spicy, acidic, or sharp food. They should take in more of cucumber and buttermilk, because these are alkalizing agents which help in healing of the lesions. Increase the intake of red and yellow fruits, because we have a good amount of lycopene content in that. Increase the intake of green leafy vegetables. Now, though we are asking them to have the diet alterations along with the exercise protocols and stress reduction, still, in what we have observed, that initially in 1 to 2 months we have to give them some additional nutritional supplements also, till our body takes over to adjust and suffice with the diet alterations that we have asked them to make for. Now, coming to the therapies. Now, as dentists, we usually follow the allopathic protocol of medications, that is the pharmacological treatment. Apart from there, we have much which has been discovered in relation to biologics, a few points in Ayurveda, naturopathy, homeopathy, and also there are some therapies which are under trial, which I'm going to explain in the further slides. So, coming to the allopathy part, the pharmacological treatment that we as dentists most commonly follow this. We can use topical corticosteroids for the mild cases. We can use systemic for the moderate cases. Then immunomodulatory and immunosuppressive agents can be used for the severe form of the disease. Any of these first four would always require an additional topical anesthetic at least in the first 3 to 4 weeks for the pain relief. Along with antimicrobials, if there is a possibility of any super added candidal infection coming in, so that is needed. But whatever medications you prescribe to the patient, always make sure that there is sufficient evidence in the literature about their safety before using it. So coming to the this is a very nice flowchart from the Journal of Oral Maxillofacial Pathology, which we can follow for treating our patients. Like, if you have examined the patient initially and it is a case of reticular non-symptomatic lichen planus, just follow up is enough. We don't have to give them any medication. But if it is a case of erosive with symptomatic, we can give topical steroids. If topical steroids in the 4 to 6 weeks are not working well, then we can give the patient systemic corticosteroids, considering that there are no contraindications for the use in that particular patient. If there is a situation where the corticosteroids are not indicated, the systemic ones, then we have to go for the therapy with retinoids or cyclosporin. and keep the patient under follow-up if you are getting a good response. If you are not getting response with systemic corticosteroids or the retinoids or cyclosporins, then the second and the third line of treatment comes to play the role. I will be dealing with it in the future slides. Now the first, let's see what is there in the first line of therapy. The first line of therapy includes topical corticosteroids, intralesional corticosteroids, systemic corticosteroids, and immunosuppressant cyclosporin. Now, which one will be used among this will depend upon the severity and the duration of the treatment that we have undertaken for the patient. Coming to the first line, that is topical corticosteroids, the first to begin with. They release the anti-inflammatory mediators which suppress the T cell proliferation. That's how they act. These are presently available in the form of ointments, gels, creams, paste, rinsing solutions, sprays, and now even the mucosal patches are also available, which are bioadhesive to the mucosa. I have put the photographs of different steroids and different brands, but I am not here like promoting though personally anyone, just to give you a representation and better understanding. Topical corticosteroids are can be categorized into low, medium, high, and very high potency. In the low potency, we have methylprednisolone 0.25%, which is more commonly used. In the medium potency, there is 0.1% triamcinolone acetate. In the high potency group, we have beclomethasone dipropionate along with betamethasone disodium phosphate. And for the stubborn cases, we can preserve the furosemide acetonide use. And in the very high potency, we have the option of clobetasol propionate, especially when there are more of disease remissions. Now, all these topical corticosteroids come up with a side effect, though temporary, of secondary candidiasis, mucosal atrophy, bad taste, dryness, dyspepsia. So, you have to keep the patient informed that when we are using these topical corticosteroids, there might be some of these side effects, but these are usually reversible after the end of the treatment. Now, coming to the erosive oral lichen planus, the combination of 0.1% triamcinolone acetonide with 2% hyaluronic acid has been found to decrease the size of the lesions. Why? Because the use of hyaluronic acid here is that it helps in the matrix organization, signaling, better cell signaling, morphogenesis, hydration of the tissue, lubrication, and an accelerated wound healing. So there are studies which have mentioned that this combination works well for the erosive oral lichen planus. Coming to the diffuse form of lichen planus, a combination of betamethasone disodium phosphate with clobetasol propionate has been found to be very successful. But just we have to keep eye on the adrenal suppression part. We should take a record of the prior renal function test, and also in the follow-ups at least once in a month. These should be done in the follow-ups to see whether all the values are in the normal range. Now, this is a case which was a case of healed lesions of systemic skin-related lichen planus. Like as you can see in the picture that there were healed lesions in relation to the dorsal aspect of the hand. There were linear keratotic striae which were observed on the nail. There was some keratinization towards the nail bed. But presently, when this patient reported, there were no systemic signs apart from the only present oral signs. It was a combination case of reticular with erosive lichen planus, and this was treated totally with topical corticosteroids, that is 0.1% of triamcinolone acetonide, and the results were good. Now, there is a modified option of topicals that is available now, that's availability in the form of patches. These are bioadhesive patches which can very nicely get adherent to the mucosal tissue. The advantage being they eliminate the disadvantage of the continuous flow of saliva which we have to face when we ask the patients to apply topicals. There is hardly enough contact time that is there between the drug and the mucosal lesions in relation to the gels. But patches, because they are resistant to the mechanical stress that the tongue might cause, there you get a very good drug distribution. So these are available now, and they are actually loaded with the therapeutic relevant doses of the drugs which are released at particular specific time points. Like clobetasol 17 propionate loaded patches are available, which are in the size of 25 to 12 mm. And they have different doses depending upon the intensity of the case. 1, 5, and 20 micrograms can be used. with 20 microgram, good enough results have been obtained. There should be at least a contact time of 1.5 to 3 hours with these patches. Now, when you are dealing with a case of desquamative gingivitis, it is very difficult to get that increased contact time of the topical gels. So, to overcome that, custom-made trays can be used. Like these are trays, basically how we have retainers that we make after the orthodontic treatment. Same, those can be extended towards the uh, gingival side, and in that we can ask the patient to apply the gel, so that this gives you better contact time, and they are found to be very good in case of especially the desquamative gingival lesions of the oral lichen planus. Now, we have seen till here the use of topical corticosteroids, which were as gels, creams, and sprays and patches. Now, suppose you have given it for a period of say 4 to 6 weeks, but enough good results were not obtained. Then you can move on to the use of intralesional injections. This again overcomes the difficulty of corticosteroids topical form, and also in such cases it can be used where you are not able to give the systemic administration like diabetes, because here in that case there might be hyperglycemia. So in such cases a safe use of intralesional injections can be done. More so in the refractory cases where, as I told, 6 to 8 weeks, after 6 to 8 weeks of follow-up, you did not get enough results. They are more better for the erosive ulcerative form. They are very effective in reducing the size, severity, and pain of the lesion. Now, how is the method of its application? Before that, the triamcinolone acetonide, that is 10 mg per ml, and dexamethasone 4 mg ml per ml is more commonly used, though there are some literatures which mention about the use of hydrocortisone also. Now, along with the discomfort that the patients were having as side effects in the topicals, here there might be an added discomfort of pain and pain during the injection procedure. There might be increased hair growth on that side and mood phases, which might be there at least for 4 to 6 weeks after. So these things should be always informed to the patient that there might be a possibility of these side effects. In the next slide, I'll tell you about how you have to use these intralesional injections. Now, the procedure is that use antiseptic. You have to disinfect the area with betadine saline, and then you have to use a insulin syringe like how we use for the diabetic patients for giving insulin, 29 gauge syringe. Now, any of these further two combinations can be used. You can either use it with the 0.5 ml of triamcinolone acetonide mixed with saline or lidocaine 2%, or you can use a combination of triamcinolone acetonide, lignocaine with hyaluronic acid. As I told in the previous slides, its effects are good over the connective tissue. So any of these combinations can be used. When we are administering these drugs, we have to give it subepithelial directly beneath the lesion, making sure that we give at least 0.1 ml equally spaced apart over and around the lesion. And this can be given once every 2 weeks or once a month, depending upon the severity of the case. Now, in relation to the intralesional injections, now there is also a therapy of giving the autologous platelet-rich plasma, which is the PRP. The reason behind using this is that it is having 3 to 5 times of the human platelets, and platelets are a very good source of these growth factors, which have been mentioned here, which accelerates the wound healing. So the procedure of making the PRP is simple: extract the blood, extract, centrifuge, and then fractionate. And addition of calcium chloride is done because calcium chloride here leads to more localized accumulation of platelets in one area, so that more of the growth factors are released in that particular location. And the injections are again given with the 29 gauge syringe. And this picture that I have put here is taken from the literature where good results were obtained with this PRP post 2 to 4 weeks. Now, coming to the use of systemic corticosteroids, now we have come to a position in the presentation where we used the topical corticosteroids, we tried with the intralesional. Now, the next step, moving on to use of systemic corticosteroids only when the lesion is not responding. So, their indications are there that we can use them for diffuse erosive lichen planus when you did not get response with the topicals, or you're dealing with a case who has mucocutaneous symptoms. Most commonly here used is methylprednisolone or prednisolone alone in the dose of 30 to 80 milligram per day, which should be definitely used only for a short period of 2 weeks. After that, we should decrease the dose to 5 to 10 mg per day for coming 2 to 4 weeks. These use of systemic corticosteroids definitely come with a lot of side effects, of which the most important that I would say is adrenal suppression, hypertension, hyperglycemia, which are the most important, and they should be always taken a record of. Now, we want to use the corticosteroids, systemic corticosteroids for the patient, but we also want safety. So there is a very good option in between somewhere there, that is the mini pulse therapy. So in mini pulse therapy, we are making use of these corticosteroids in the systemic way only, but in very controlled doses and over a period of time. That is, like here we can use an option of betamethasone 5 mg OD for 2 consecutive days a week. So we are just giving for 2 days a week. That too OD dose is given for the coming 2 to 3 months, and we have to gradually taper down this dose. Suppose if you are giving 3 times consecutive days per week, the next week, if there is good recovery, it should be followed up and decreased further to 2 times. Similarly, methylprednisolone 10 mg also works very good. This is what we have used in most of our cases, mini pulse therapy, and it has been found that the mini pulse therapy is much more effective than the use of 0.1% of triamcinolone acetonide. And again, the other advantage is that side effects with these mini pulse therapy are really rare, or if they are there also, they are reversible. So I will show you in the next slides few cases that we treated with the mini pulse therapy. Now here is a case of reticular with mild erosive form post 4 months. Good enough healing was obtained. Here, methylprednisolone was used 10 mg as in 3 consecutive days dose per week, starting in the beginning, which was tapered down over the coming weeks. The other case, which is of a dental treatment related stress and anxiety case, this patient was around 45-year-old male patient who had undergone traumatic surgical extraction in a clinician's OPD, and 4/8 was extracted. And after almost 8 to 10 days of extraction, patient developed generalized lesions throughout the oral cavity, right from right and left buccal mucosa. There were small vesicle eruptions here and there. There was desquamative gingivitis too. So this was again treated with mini pulse therapy along with stress relief and lifestyle alterations, and what we told in the first slide. And post 2 months, good enough healing was obtained. So the last we have skipped. This is the treatment result that we obtained post 2 months. Now, this is a case of around 55-year-old female patient who had erosive form of lichen planus in relation to the right post-retromolar area, along with some blistering lesions in relation to the right lateral border of the tongue. So even this was treated with mini pulse therapy, and good enough results were obtained. A case of desquamative gingivitis, which was also treated with mini pulse therapy along with some topical agents, and post 3 weeks, considerable good results were obtained. Now, coming to the other options that we have, patients in whom we are not able to use the systemic corticosteroids, we will go for these medications. That is cyclosporin in the category of macrolide. It inhibits the T lymphocyte functioning and proliferation and decreases the immune response. Now, the use of cyclosporin is recommended only in topical form, but a little disadvantage on this side is that it is more costly as a drug to be used. This should be reserved for the stubborn cases, and they are also now available as mouthwash and adhesive patches. And once a control of the lesion has been obtained later on, they can be continued with 0.1% of triamcinolone acetate. As you can see here in this is a case which has been taken from the literature where cyclosporin was used topically, and it gave good response. Now here I would like to mention that the systemic use of cyclosporin should not be done. Next, coming to the use of retinoids, vitamin D and selenium, this has also been mentioned in the literature. Why? It's a previous slide. Retinoids, why should they be used? They are metabolites of vitamin A, and they are needed for the growth and proliferation of the epithelial cells, whose deficiency causes keratinization. I would like to mention here that they should be used only in the topical forms, and the medications that are available are retinoin 0.1% and isotretinoin 0.1%. It should definitely not be used in systemic way because it has a teratogenic effect. It should be avoided definitely in a female fertile patient. The use of vitamin D also has been proposed basically because of its immunomodulatory and anti-inflammatory properties. Selenium because of its antioxidant properties, which can be used as a topical gel for a period of 6 weeks. Coming to the immunomodulatory drug, levamisole is a drug of choice. It is actually an anti-helminthic drug, but because of its immunomodulatory properties of increasing and restoring the phagocytic activity of macrophages and neutrophils, its use has been recommended in 50 mg dose thrice a day for 3 consecutive days, which can be taken for the period of 15 days to 3 months, depending upon the intensity of the lesion. Its use has been recommended also in many studies and case series as monotherapy, like just use of levamisole as a monotherapy has been found to heal the lesion. Showing you here a case of levamisole which was used as a monotherapy. So it was in the previous slide. This is a case which was treated with levamisole and good results were obtained. Now coming to the second line of therapy, I will detail about all these in the future slides. First, starting with the topical calcineurin inhibitors. Now these are preferred for the recalcitrant cases of erosive oral lichen planus, in which we have two options, that is tacrolimus and pimecrolimus. Tacrolimus in the percentage of 0.03 to 0.1, it has a very good penetrability into the oral mucosa, and it can be used both as a topical gel and as a mouthwash. The other option is pimecrolimus, though less commonly used because of its disadvantage of high price and unpleasant taste, mucosal burning, and also the side effect of carcinogenicity. So there are few reports pertaining to the use of pimecrolimus, as you can see in this picture. Other drug therapies, there is mention also about the use of tetracycline, which has been found to be more effective in the gingival lesions, that is the desquamated gingivitis, but its routine use is not recommended basically because of the teratogenic effect that it can cause. There has been literature about antimalarials being used, and they are more commonly used for like erosive oral lichen planus, a combination of hydroxychloroquine with chloroquine phosphate, which but when they are used we have to keep a check on the side effects of especially the ocular toxicity that it can cause, the pigmentation, the lichenoid reactions. Now in the further two slides I'll tell you about the drugs and which have been mentioned in the literature, but there is a relatively little evidence, limited evidence, like azithromycin, which is decreases the T and B cell proliferation. It's an anti-metabolite, but off-label therapy presently much not used because for oral lichen planus because of its significant side effects of leukopenia, pancytopenia, liver dysfunction that it can cause. Same way, mycophenolate mofetil, it has a cytostatic effect on lymphocytes, and that is why its uses again weak in the literature. Tried but limited evidence. Again, there are two more such medications, methotrexate, because it also decreases the DNA synthesis and cell proliferation. Same way, sulfasalazine also, because both of these drugs have been tried, but because of their systemic side effects that they could cause, they are not much in use for oral lichen planus. Now coming to biologics, what are biologics? Biologics are basically materials which are formed or obtained from any living matter. It could be humans or animals or microorganisms, components of the blood, anything like that. So there is a lot of research in relation to biologics that is going on. Though they are used for many systemic skin-related pathologies, the use in oral lichen planus is still in its preliminary stage, and they have been tried in few cases of refractory oral lichen planus. The whole concept of using here is they are generating the antibody related to the various antigens that we read in the pathogenesis, like interleukin 17, tumor necrosis factor alpha, interleukin 23, 2 and 17 related antibodies, which are used in this biologics category. The third line of therapy, now this is in this there are three categories: the low level laser therapy, the photobiomodulation or the photodynamic therapy, and nutraceuticals. Now I would say here that in all these therapy, though they have been evidence for their efficacy, but their evidence is low because there is not much discovered or studied, or we are getting only single cases here and there as case reports or small cohort studies. So there are good results which have been obtained in these. small cohort studies and single case reports, and more such long-term studies should be done in this aspect. Starting with the first, that is the low-level laser therapy. Here, basically, the objective is to stimulate the fibroblast and epithelial cells for better healing. There are different options of laser available. More commonly used is a 660 nanometer of diode laser, which is used for like 5 minutes session and we can make use of such 2 sessions per week for coming 4 to 6 weeks. And the healing obtained has been found to be good. This is again a picture that I have taken from the literature where low-level laser therapy responded. The patient responded really well. Next, coming to the photobiomodulation. In photobiomodulation, what actually happens is that we apply a photosensitizer over the mucosa, which could be like methylene blue or toluidine blue, and the light is exposed onto this lesion. Because of this photobiomodulation, the cytotoxic free radicals are produced, which decrease the CD4 plus then CD8 plus cells along with the interleukin 17. And again, here the wavelength is 630 to 660 nanometer. Photodynamic therapy has also been found to be good with the topical in conjunction with topical corticosteroid use. And they can be very well and safely used for patients in whom the systemic corticosteroids are contraindicated. Now, especially in cases where the relapse are more common and more stronger symptoms are there. There are also evidences in the literature where free soft tissue grafts from the like say posterolateral mucosal part has been grafted and placed. And at least as what I observed in these case reports that at least after 1.5 to 2 years of follow-up, most of the time there was no recurrence which was found. So this should be just taken as the last option when the other things are not working. Coming to the ongoing trials, in short, Janus kinase inhibitors, which are basically they participate at the cell membrane at the cytoplasm level for the transcription pathway. So their inhibitors like baricitinib and upadacitinib, they are used. They are as blockers of this Janus kinase inhibitor pathway, and this helps in the reduction of the lesion because they decrease the amount of the inflammation in the local area. And there are the trials related to these are more of in the preclinical phase. So these are used in the other, as I told, in the systemic mucocutaneous diseases. But the use in oral lichen planus is still in the preclinical trial phase. And mesenchymal stem cells, their use has also been potentiated. The reason behind the use is that the researchers are thought that possibly the mechanism that happens in the epithelial cells is responsible for bringing in the T cells, the natural killer cells, to the site to cause the apoptosis. So, if mesenchymal cells could be used to, create an effect as a switcher of the immune system, it be helpful in the case of lichen planus. Now, interference RNAs, these are used in the drug-resistant diseases. These are microRNAs, which are the small non-coding RNAs, which regulate gene expression. 11 potential microRNAs have been found, of which microRNA 214, that is 214, has been found to specially target the CD44, which is the pathology in the oral lichen planus. Now, till here we have read in a lot of detail about the pharmacology that we could use, the pharmacological drugs of allopathy. So I would like to say here there are many things which can be picked up from Ayurveda and combined with our pharmacological drugs that we are giving in allopathy, and very good results can be obtained because there are a lot of good case reports which have been published in relation to this. When we look at Ayurveda, they consider oral lichen planus developing because of imbalance of the various doshas which accumulate in the body. And they consider the triggers same as what we consider, that stress, improper diet and lifestyle imbalances. So for treatment part, Panchakarma, so for Panchakarma, definitely we need to take the help of a specialist in this. But at least the other part, I think, and I would suggest everybody that we should try to encourage our patients to use, like say Triphala, then honey, ghee. These are all very commonly available, licorice, which we should ask and promote the patient to use. And what we believe that at least after the first 1 month of therapy, topical or systemic, whichever is working good, at least after 1 month, we should incorporate some of these aspects in our patients also and promote them to use them. because this is something that will sustain for more time and help us compared to the continuous use of steroids. Then they also promote the use of rasayan therapy, that is Chyawanprash, ashwagandha intake, curcumin in 5% because of its anti-inflammatory and anti-cancer properties. The naturopathy aspect, the naturopathy again believes it to be because of chronic inflammation. So they also focus on identification of the root cause, stress reduction, and a lot of detoxification procedure like with hot and cold rinses and intake of herbal teas. The anti-inflammatory diet should be promoted. Food rich in omega-3 fatty acid, alkalizing food that we also mentioned in the previous slide. Allergens should be avoided and nutritional deficiency should be compensated for, along with restoring gut health with probiotics. So we should always, whatever at our level, we should try to promote these things in the therapy part when we are dealing with the case of oral lichen planus. Next. Now, a combination of aloe vera, sesame oil, licorice has been found to decrease 95% of burning sensation. Curcumin in itself has also been found to decrease almost 90 to 95% of the burning sensation in patients. There are other few topicals that can be used and they are very handily available also in the houses like coconut oil, honey, tea grass oil, yogurt use. Now, to almost we are at the end of the presentation. Now, here, whatever treatment therapy that I told till now was for the case of pure oral lichen planus without dysplasia. What when your case is having histopathologically dysplasia? So, in such case, removal of the lesion and close monitoring would be the first choice. That is, and also you should be keeping the patient under follow up at least every 2 to 3 months to check whether there is any suspicious change that is occurring in the lesion. So follow up is very important in such cases. Last but very important part, oral lichen planus is in the children. So this is also very much possible because oral lichen planus in children accounts for almost 3% of the cases. And we have to keep one thing in mind that oral lesions, when it comes to children, they might be accompanying cases of vulvar lichen planus. So we have to check for that. Now, as far as the treatment part is concerned, the reticular and asymptomatic lichen planus, they should not be given any pharmacological treatment. Just follow up is enough. Now, coming to the erosive forms where there is symptom for the patient. So, as per literature, it was mentioned many places that the topical corticosteroids should be used. But somewhere I feel and believe that rather than using the topical corticosteroids, we should prefer using the topical retinoids and low laser therapy in these patients because they are more better and safer alternative rather than exposing the children to the corticosteroids. But yes, they will have to be used when there is no enough relief of the symptom. So to conclude, I would say a case of oral lichen planus, in a case we have to have a integrated medicine plan. We should make use of allopathy along with few concepts of Ayurveda, diet alterations and lifestyle alterations like exercising and all those things as we mentioned, and try to give our patient a more integrative treatment plan so that we are able to avoid the recurrences of these lesions and the patient can continue with some home based continuum of self care which will help in preventing the occurrence of these lesions. With this I conclude my presentation.